Welcome. My name is Anya. I will be presenting a case on hypertriglyceridemia. Mr. Glenn Lipid is a 56-year-old man with triglycerides of 982. The rest of his lipid profile is a total cholesterol of 232, HDL of 28, and LDL of 106. He is adamant about not taking TRILIPICs because of the cost. His vital signs are assessed at admission to the office. His blood pressure is 130/73, slight hypertension. His pulse is 90, respiratory rate 16, pulse ox is 98, height 5'9", weight 175, and reports no pain. His first lipid profile was performed last visit. He is self-employed and uninsured, so he does not regularly seek medical care. He was diagnosed with stage 1 hypertension last visit with recommendation to alter diet and increase exercise. His relevant family history is that his mother has type 2 diabetes mellitus and COPD. His father has hypertension, high cholesterol, and is overweight. Relevant social history is that he drinks over 3 drinks 4 times a week. He is currently a non-smoker. Quit 10 years ago, but he did report that he was a pack-a-day smoker for 20 years. He reports that he is very active in his job. He's a stonemason. His current medications are none, and he reports an allergy to cats. Given his high triglyceride level, it's important to perform a few labs to rule out the possibility of secondary factors contributing to the hypertriglyceridemia. Diabetes has to be ruled out, hypothyroidism, chronic liver disease, and chronic kidney disease, and or nephrotic syndrome. The only elevated labs that came back were his liver function studies, and that could be contributed to his high alcohol intake. It's important to assess his ASCVD risk. He would be borderline risk if he did not have persistently elevated triglycerides, but with those, his calculated risk is at an intermediate level of 10.5%. The AHA and the ACC guidelines endorse statins for severe hypertriglyceridemia with an ASCVD equal to or greater than 7.5%. Acute pancreatitis also has to be factored into this risk because his levels of triglycerides are over 500 milligram per deciliter. However, the Endocrine Society puts this at a moderate hypertriglyceridemia level and says that CVD is the primary risk in this category. The goal of therapy here is to reduce the ASCVD and his risk of acute pancreatitis. Lifestyle modifications are the primary goal. Recommending a diet very low in fat and carbohydrates, specifically avoidance of refined carbs. Recommending cardiovascular exercise, running, cycling, rowing, brisk walking of 150 minutes of moderate intensity or 75 minutes of vigorous intensity a week. And attempting to reduce his alcohol intake to no more than 1 drink per day, preferably no drinks per day, but I'm not sure how successful that would be with this particular client. The pharmacological therapy, the Fredrickson classification of type 4 recommends fibric acid derivatives like fenofibrate, 67 to 200 milligrams every day, which contradicts the 2018 recommendation of the American Heart Association and the American Cardiology guidelines, which recommend a moderate intensity statin as the first line. Atorvastatin 20 milligrams by mouth every day, with increasing the dose every 1 to 4 weeks for a maximum of 80 milligrams per day. Along with a statin, we can add a non-statin, ezetimibe. Niacin and fibrates, however, should not be added alongside a statin because research does not support this use. Atorvastatin and its metabolites are pharmacologically active. The liver is the primary site of action and the principal site of cholesterol synthesis and LDL clearance. Individualization of drug dosage should be based on therapeutic response. The mechanism of action is selective competitive inhibitor of HMG-CoA reductase. It lowers plasma cholesterol and lipoprotein levels. It does this by inhibiting HMG-CoA reductase and cholesterol synthesis in the liver. It increases number of hepatic LDL receptors on cell surface, enhances uptake and catabolism of LDL, and reduces LDL production and number of LDL particles. Absorption, the max plasma concentration is within 1 to 2 hours after oral administration, and absorption increases in proportion to dose. The bioavailability is 14%. Systemic availability of HMG-CoA reductase inhibitory activity is 30%. Pre-systemic clearance in GI mucosa and or hepatic first-pass metabolism. The distribution is over or equal to 98% bound to plasma proteins. It is extensively metabolized to ortho and para-hydroxylated derivatives and various beta oxidation products. 70% of circulated inhibitory activity to HMG-CoA reductase is attributed to active metabolites. Atorvastatin and metabolites eliminated primarily in the bile following hepatic and or extrahepatic metabolism. Plasma elimination half-life is 14 hours. Half-life of inhibitory activity for HMG-CoA reductase is 20 to 30 hours because of the metabolites. Under 2% is excreted in the urine. Risk of myopathy is greatly increased if atorvastatin is used with fibrates or niacin. Grapefruit products actually decrease the effectivity of atorvastatin, and with alcohol, it increases damage to the liver. Common adverse reactions that the patient should know about are diarrhea and indigestion, nasopharyngitis, arthralgia, non-serious and reversible cognitive effects, myalgia, insomnia, and headache. I don't want to stress the importance of eliminating alcohol, altering his diet, and regular exercise. These lifestyle changes can lower his triglyceride level by up to 20 to 30% on their own without medication. And for some people, alcohol dramatically increases triglyceride levels, so I would advise him to abstain for 2 weeks prior to his next appointment, if at all possible. I provide education on pancreatitis and the seriousness of acute pancreatitis. I'd want him to notify me with any mid-epigastric or left upper quadrant pain that radiates to his back, accompanied by nausea, vomiting, lightheadedness, sweating, or a racing heart. I'd provide some education on cardiovascular disease and the stroke and heart attack risk and how much they would impact his daily life or lack thereof without any of these changes. I'd advise that he take his medication at the same time every day. Because of his high starting point of triglycerides, statins can lower his triglyceride level by 22 to 45%. They are not as effective with a triglyceride level starting at like 210, but because it's so high, they are more effective. These medications will reduce his cholesterol and his risk of heart attack and stroke, and reduce his overall mortality. He's to call a provider with any new onset muscle pain. If he experiences myalgia, it is probably statin-induced if it's bilateral or it involves the proximal muscles. If it starts within weeks or months after he starts this med, and it resolves after discontinuation. So I'm going to have him come back to me in 2 to 4 weeks to reassess his triglyceride levels, and if they remain elevated above 500 milligrams per deciliter, or if they perchance increase, we will be considering fibrate therapy in lieu of statins. The overall goal is to reduce his triglycerides to below 500 milligram per deciliter, so he is no longer at risk of acute pancreatitis. And that concludes my presentation. Have a very wonderful day.